So we will briefly go through this movement disorder. As you know, like any other topic, this also vast. Just we will go through basic aspects. You can ask doubts. If I know, I will clarify. Now, what I do not know, we'll read together. So that's the thing. We will define the various terms, then go through some anatomy, physiology, and motor control approach, and some key points. Like that, we'll go. And as you know, what constitutes extrapyramidal system? You see, all that is not pyramidal is extrapyramidal. Among the motor systems, whichever is not pyramidal, we call it as extrapyramidal, and that extrapyramidal constitutes striato-pallidonigral system, that is the basal ganglia, and cerebellum, that you know the equilibrium controlling. So extrapyramidal system means not just basal ganglia, it includes the cerebellum. Conventionally, we exclude cerebellum, but it includes both. So now, but we will be today not going through balance also. We will only see the basal ganglia part of it. And what is basal ganglia? It forms a group of subcortical nuclei situated in the proximity of the thalamus and hypothalamus. So that all of us know. So that is why it is called basal ganglia. And the main structures include striatum, pallidum, substantia nigra, pars compacta, pars reticulata, and subthalamic nucleus. So striatum is cardiac nucleus and putamen, pallidum is globus pallidus, we know all those things. And these regions connect to the cortex. So it is in the subcortex, a collection of gray matter in the subcortex, which is intermediary between the spinal cord and the cortex. So it receives information from the cortex, transforms the spinal cord, modulate functions based on the demand situation, and converts it into a motor schema. That is the activity of the basal ganglia. So here we can see the structures. All of you know this, but we will see. You see, this is the caudate nucleus, and this is the putamen. This is globus pallidus, interna, externa, and we have got the thalamus. Thalamus is not technically included under basal ganglia, even though it is a most important relay station in the extrapyramidal motor control. So if you are asked short notes, we don't write about thalamus, but we will tell about the modulatory effect of the thalamic nuclei. So this is caudate, putamen, globus pallidus, interna, externa. This is substantia nigra, and below the thalamus we have got the subthalamic nucleus. So these are the various structures, and in the then we have got the substantia nigra has got two parts. One is the pars reticulata, another is the pars compacta. So that is in short the subcortical gray matter. And this is another view. This is what we mostly see. We have the substantia nigra, the mineralized part of the midbrain, and that is there. And this is the same structures which I just elaborated. This is the live brain which is dissected, showing the structures, and this is diagrammatic picture. Here you see the thalamus, and here you see the subthalamus. So this mild contrast, you have to recognize these structures. Here you have the caudate nucleus, and this is the putamen, this is the globus pallidus, and this is the substantia nigra here. So then we have got another structure called the ventral pallidum. So here the most important part is the mammillary body. And mammillary body, and you also have got thalamus is not conventionally involved, as I told. Subthalamic nucleus is there, and the mammillary body is there. Then another important system we should know in the motor control is the nucleus accumbens. It is otherwise called as the reward system. You do the right movements, it gives you the happiness because it contains dopamine, which will be released, and it gives a feeling of happiness to the individual that helps us to do the right thing again and again. So nucleus accumbens is linked to the mesolimbic dopaminergic reward system, and it is situated between the caudate and the putamen in the basal forebrain, and it is called as the ventral striatum, part of the ventral striatum. Ventral striatum also includes olfactory tubercles and all those structures, but so that is part of the ventral striatum, and it contains dopamine, important for motivation. Motivation comes through reward. Whatever is appreciated will grow. Whatever is not appreciated will die. That is why students or children or even old people like us want to be appreciated. It is really true that my teacher used to tell that it is when you grow old also, if you want to continue to do your activity, you want to listen the students smiling and they are telling good and wanting to present every Wednesday. All those things are forming part of the reward system for older people like me also. No? Because my teacher used to tell, when you grow old, you really do not grow too old and different unless you become a saint or a sannyasi. It is like a Chinese feet only, but wearing the Japanese shoe and walk. You are forced to wear like that. So all of us need to be appreciated, the children to the adults, so that good things progress in this world. No? So that's a reward system. And this is the nucleus accumbens in the basal forebrain. This is the caudate nucleus. I said it's a caudate nucleus. This is a nucleus accumbens. So now, we have seen the gray matter structures. Now we will come to the tracts. The gray matter in the subcortical gray matter is connected through various tracts, I saw. And these tracts are called as the extrapyramidal tracts. So what are these extrapyramidal tracts? It is constituted by fibers arising from the motor cortex, which do not enter the pyramidal tract. So again, it comes from the cortical area, which link with the extrapyramidal system. So they do not arise from the, they do not enter the pyramidal tract, so they are extrapyramidal. They relay in various parts of the brain. Where do they relay? One is basal ganglia. So basal ganglia, red nucleus, reticular formation of the brainstem, vestibular nucleus, and forms a multi-synaptic pathway, because as you know, nervous system cannot function independently. Like all human beings, all of us need an enormous team. Like in Tamil, there is a poem, if the people who weave do not weave, what dress you will have? No? If the people who make vessels do not make, how you will cook with all your money? So it's a system. It is a group which works together. It is not one person. Same way, neuraxis needs the reticular activating system for alerting, reward system, accumbens. So all these things are together working. That is by communication through various pathways that I will come to. And the function is concerned with the regulation of muscle tone, posture, and equilibrium. So with all these basal ganglia connecting with the cortex, having various tracts and communicating to the spinal cord, it ultimately controls muscle tone, posture, and equilibrium. So that is the ultimate function, you know, rigidity, and we have had one session on tone, I think. So ultimately, what is motor control? Motor control is ability to regulate and direct the mechanisms essential for movement. So it has to be regulated. Unregulated movement cannot take place. It will become very half-assed. So how does it happen? You have a task. You want to go to your hospital. So that is your task. And you have got an environment through which you move. And you have got an individual. All these things should be properly coordinated. So the task, the environment, and the individual. For that, a lot of calculation is needed. So that calculation is called motor control. You have a task and you have got an environment, you have got the individual. That needs proper calculation. So many vehicles are moving in the road. Very rarely only accidents happen, even though they do happen. But that is to be prevented. That is mostly prevented because of this motor control, which is a coordinated execution of task, individual and the environment related motor goals. So what does this basal ganglia do to achieve this motor task? It selects appropriate motor and behavioral output in a particular context. Motor means how fast, how slow, how graceful. Supposing it is beauty context, you should not run. You should gracefully, slowly move. Supposing you are in front of a thief, you should run. And behavioral aspect is important, because in front of a lion, you cannot dance and stand there. But in front of beautiful things, you can stand and watch. So it contains a behavioral component there for the context. So it selects the appropriate motor and behavioral output in a particular context. And there is a strong convergence of corticostriatal projections from the cortex. to control the cognitive aspect of motor function. And there is a topographic arrangement. So dorsolateral sensory motor. That is, sensory motor cortex is having connection to the basal ganglia, because motor functions do not happen without sensory function. You see, when you touch fire, you do the motor activity of moving your limb away from that. So they coexist. And central is associative. It associates the sensory information and decides the motor task and formulate the schema. And ventral limbic is the reward system, which we saw. So this movement is correct, so you get a reward for that. That movement is wrong, you get punished for that. But exact ultimate structure that chooses which is the how to do the sensory motor coordination, consider the association of various movements in carrying out the activity, and which one you reward. All this has got a cognition of cognition. That is called cognition of cognition. We do not know. So how are you having your cognitive activities? We know that frontal lobe is personality, temporal lobe is memory, parietal lobe is spatial orientation. But because that is by seeing what these structures, when they are ablated, you lose. But who did all this? That is called cognition of cognition. No? That we do not know. So the exact neural structure command to say what is right and wrong, that is the supercognition or cognition of cognition, we do not know. So this is supposed to happen through a 3-tier system. The first tier is the highest level of motor control, that is the cerebral cortex, the motor areas, area 4, area 6, that is the cerebral cortex. And middle level of motor control is the structures which we saw, including the cerebellum. And the lowest level of motor control is the cranial nerve nuclei in the brainstem and the spinal cord. So it's a 3-tier motor control using the cortical structures, the subcortical structures, and the muscles innervated by the motor nerves of the through the cranial nerves, as well as the spinal cord and the spinal nerves. So that is the 3-tier system of motor control. So we'll go one by one. What are these systems? One is the primary motor cortex, which is area 4. And it is concerned with initiation of voluntary movement. So area 4, initiation of voluntary movement on the opposite side. In front of the area 4, you have got the premotor area, which we call as the area 6. And what does the area 6 do? It coordinates voluntary activity. Supposing the area 4 tells move your right hand and lift it above your head. That is the command given by the motor area. So who is telling which muscle should, deltoid should abduct, trapezius should help, triceps should extend, fingers should extend. So that schema, that is done by the, okay, you want me to move the right hand. So the supplementary motor area or area 6 will give the schema. Who should be agonist, who should be antagonist, who should be synergist. So it prepares the schema and coordinates the command given by the motor area and coordinates voluntary actions of area 4 and extrapyramidal system. It assists in integration of sensory motor information and it produces a smooth, accurate motor activity, which is called praxis. So in the absence of paralysis, you cannot imagine that you can do all the activities properly if the praxis control system is not there. So in a non-paretic limb, there is a schema that is called praxis. So that praxis component is mainly by the area 6 in the supplementary motor area. And supplementary motor area has got a medial part in the parasagittal zone. So that is rostral to the primary motor area, and it is responsible for generating the idea, planning and programming of movement in the basal ganglion cerebellum. And one special thing you have to remember, supplementary motor area and supplementary sensory area and frontal eye field are 3 important structures. That is area 6, area 7 and area 8. That is frontal eye field, supplementary motor area, and area 7 is supplementary sensory area. They are having bilateral control. So area 6 is having both ipsilateral and contralateral control. And it needs simultaneous input from the substantia nigra and the cortex. So from below and from above, that is called different copy signal. Supposing I am doing a wrong movement, that information is given to the cortex. So it will correct it. So that is why from below it receives information and above it receives the command. integrates the input, even subthreshold one. And that is happening through various neurotransmitters, mainly the GABA, which is inhibitory, and dopamine and glutamate, which is facilitatory. So that I'll come to later. And area 6 is frontal eye field. It is concerned with control of eye movement. It is very important. You have to see where you have to run towards or run away. For that, eye movements are important. So they are all linked. So that is the higher components of somatic motor control involves area 4, area 6, area 8, and the various transmitters, and their link with the subcortex and the cortex. So here I have just showed the homunculus. You better to remember this very many times I would have shown, because it is a lot of clinical relevance. Cerebral paraplegia plus spinal paraplegia. I always tell you, see the motor part, it is from the hip. The sensory is from the angle. So supposing you have a lesion here, patient will have weakness from below the hip, and sensory will be below the angle. So you will think it is peripheral neuropathy. So, but when you elicit the reflex will be preserved and the sensory loss will be cortical. So cerebral paraplegia can apparently be, if you are not carefully examining, easily missed as a compressive myelopathy with the peripheral neuropathy, subacute combined degeneration. You forget to image the brain and you will miss a Fox cerebri meningioma. So that is, remember this. So that is very important. Then sensory system in motor control. That is called a positive. What is the role of sensory system? I said sensory system has got an important role in motor control. So that is called positive cortical tropism and phenomena of agency. Supposing you know your situations where you have alien hand, you think your hand is not yours. That is because there is no phenomena of agency. So positive cortical tropism means, I will tell in a simple example. Supposing a student is there and the student is communicating with the teacher his everyday progress. He will say, I have studied chapter number 1 today, sir, and I had some difficulty in this area. Then the teacher will definitely know this boy is my student. But if the student just comes and goes away, the teacher will not know. So the teacher will not take agency, and the exam teacher will say, I do not know this boy. So that is called phenomena of agency. So when the sensory information regarding the position in which your body part is there is constantly conveyed to the brain, so that the motor output understands that the motor command is being carried out properly. So the brain will say, okay, this body belongs to me, and I have told this boy to abduct the deltoid, but he is adducting the hand. So immediately give a corrective command and change it. So you know it is your own self, you are giving information, and the information conveyed is correct or wrong is decided by the cortex, and cortex will know this body part is mine. So that is called positive cortical tropism, is continuously giving information to the cortex. And phenomena of agency, you are giving me information, I know your mind, and I correct your mistakes, and I appreciate the right things, and so that is phenomena of agency. So that is the importance of sensory system in motor control. So now we have seen the cortex to the subcortex, the cortical area which connects with subcortical area, area 4, area 6, area 8, and the sensory areas which is having some importance. Then we will come to the input pathway and the output pathway of the basal ganglia. So first we saw the basal ganglia structures, then we saw the cortical structures which connect to the basal ganglia. Now we want to see what are the input tracks and the output tracks. The caudate nucleus and the putamen form the main site for receiving input. So the major input pathway is striatum or corticostriatopalydovital like that. So striatum or the caudate nucleus and the putamen forms the main input pathway to the basal ganglia. What pallidothalamic, that's the outflow. So outflow is through the globus pallidus. So the major input or the major structures which receive information from the cortex is the striatum, otherwise caudate nucleus and the putamen. The major structures which transmits information to other areas is the pallidum, globus pallidus, forms the major site from which the output leaves the basal ganglia. And they do not have direct connection to the spinal cord. Instead, they are connected to the spinal cord through various brainstem nucleus, the vestibular nucleus, the reticular nucleus, the red nucleus, and they relate to the various brainstem nuclei, and these brainstem nucleus connect to the spinal cord. So that is the there is so much complex in this. We will not need that. Just to know the basic, very clear principle that input is through the striatum, output is through the pallidum, and to the spinal cord, it is through the brainstem nuclei. So input through the striatum, output through the pallidum, to the spinal cord, output is through the brainstem nuclei, not directly to the ventral horns in the spinal cord. So then we know that in the classes, we always describe the circuits in the basal ganglia. So that which connects the cortex, the basal ganglia, and carry the information to the brainstem. We have got 3 important pathways: direct pathway, indirect pathway, and hyperdirect pathway, and 2 more substantia nigrostriatal and striatonigral. But always direct, indirect, and hyperdirect, we should not forget. The direct pathway is cortico. These are cortex. We have seen what are the structures in the cortex. We know the striatum is the input, so striato, then pallido, so cortico, striato, pallido, thalamo, cortical. That's a direct pathway. So cortico, striato, pallido, thalamo, cortical. That's a direct pathway. In the direct pathway, the globus pallidus is only interna. What is the indirect pathway? Cortico, striato, pallido, thalamo. Here the pallidum is externa. Then comes the interna. Then the subthalamic nucleus. Then you have got the cortico, striato, pallido, globus pallidus. You have got externa, then subthalamic nucleus, then interno, pallidothalamo-cortical. So direct pathway is cortico, striato, pallido, thalamo, cortical. In that, globus pallidus is interna. Indirect pathway is you have got addition of globus pallidus externa and subthalamic nucleus. After the cortico, striato, there is addition of globus pallidus externa and subthalamic nucleus. Then you have got the interna, pallidothalamo-cortical. Hyperdirect pathway is cortico, subthalamo-cortical. Because this picture is overlapping, I'm not able to. So cortico, subthalamo-cortical is hyperdirect. Cortico, striato, pallido, where interna is direct pathway. Cortico, striato, pallido, externa, subthalamic nucleus, then interna, pallidothalamo-cortical. That is the indirect pathway. Then you have got the hyperdirect is cortico, subthalamo-cortical. So these are the 3 main links where all these structures which we see are connected functionally. I will tell this again. So what are the functions of these pathways? So they have to facilitate the desired movement and they have to inhibit unwanted movement. So when we attend a class, we cannot obviously go for a filling. So you have to inhibit the desire for that. So you have to facilitate a desired movement and inhibit an unwanted movement and provide feedback mechanism and correction of the movement when it becomes erroneous. So these pathways, 3 important things. One is facilitate the desired movement, inhibit the unwanted movement, and provide feedback mechanism and corrections of erroneous movement. So whenever movement becomes erroneous, immediately give a correction and try to constantly monitor vigilantly and correct. So these are the 3 important functions which these pathways do. So direct pathway selectively facilitates certain motor programs in the cerebral cortex that are important for carrying out that task. That is the direct pathway. Indirect pathway inhibits the competing pathways. So that is, it is inhibiting the antagonistic movement. So in direct pathway facilitates the agonistic movement. Indirect pathway inhibits the antagonistic movement, and hyperdirect pathway corrects the erroneous movement. So cortico, striato, pallido, thalamo, cortical, direct pathway. It is facilitating the set goal. And indirect pathway, which includes the you have got subthalamic nucleus and the globus pallidus externa incorporated into the striatal circuit before it is completed. That is inhibiting the antagonist. and hyperdirect is suppressing the erroneous movement. So I think it is clear. If needed, I can tell also again. So direct pathway directs towards the set goal. Indirect pathway inhibits the antagonist. Hyperdirect corrects erroneous movement. So this is 3 important pathways. So we have got the D1 receptor in the direct pathway. It is excitatory or facilitatory. So dopamine, it is carried through neurotransmitters. Pathways are there. Pathways execute their movements through neurotransmitter. So dopamine in the direct pathway is excitatory or facilitatory. It facilitates the goal-directed movement. And in the indirect pathway, it is through the D2 receptors and it inhibits the antagonist. So that is in the indirect pathway. Then we have got, apart from these pathways which are inside the basal ganglia, we have got some cortical loops, that is the cognitive loops which connect to the basal ganglia and responsible for some of the symptoms which happens in basal ganglia disorder patients. So they always look depressed because executive control is lost. So for that, you have got 5 loops. So now I have said about the basal ganglia, what are the structures it is connected to the cortex and the brainstem nuclei which connected to the spinal cord. Then we saw what is direct pathway, what is indirect pathway, what is hyperdirect pathway. So agonist, antagonist, synergist. So this, as you know, motor disorder, basal ganglia, it's a huge books. So many books are there. It's a simplified version, but it's a correct alphabet. If you know this, you can easily build on this. No? And you have got 5 cortico-basal ganglia thalamocortical loops. They are called as motor loops. Motor loops is area 4. Area 4 connecting to the subcortex is motor loop. Oculomotor loop, that is area 8. Area 8 connecting to the subcortex is through the oculomotor loop. You know that PSP patients, even the classical PD patients have so many kinds of eye movement problems. That is because of the oculomotor loop. Associative or dorsolateral prefrontal. That is the executive function. Associative loop is otherwise called dorsolateral prefrontal. That is executive function. Okay, you have to go to your college by 8 o'clock. So you have to plan, execute, and get out of your bed and prepare and go. Instead, you sleep till 8 o'clock. Then you say, okay, I'm late, I cannot go. So that is the dorsolateral prefrontal cortex. Then the limbic, I said the reward system, the accumbens, that research the motivational aspect of if you study properly now, you become good doctors, you will serve your country. And when you die, you are going to leave footprints. No, that's the most important thing. So you correctly get the knowledge, execute it. So gods will act through your hands and give correct results in your patients. And when we are dead, patients will tell, oh, this doctor lived in this earth and he helped many people. No? So that is the reward system. They have got the orbitofrontal, medial orbitofrontal. That is concerned with the preservation of self and species. Medial orbitofrontal, you know that even mentally retarded people, if you beat their children, they become aggressive. Animals begin. That is preservation of self and species related circuit. So their motivation will be preserved till late in these circuits. So that is medial orbitofrontal. That is through self and preservation of self. For self and species related motivation, it is medial orbitofrontal. Limbic is reward based. Dorsolateral prefrontal is executive function. Oculomotor is eye movement control. Motor is motor plan. So in addition, the basal ganglia is intimately interconnected with the brainstem nucleus, such as locus coeruleus, that is noradrenergic, raphe nucleus, serotonergic, and cholinergic reticular formation. So apart from dopamine and GABA, you have got other neurotransmitters which also play important role through the brainstem nuclei. That is noradrenergic in the locus coeruleus, autonomic functions, PSP patients, MSA patients, no, these structures degenerate. Even the faults are mediated through these structures, not through dopamine. And you have got the cholinergic reticular formation. So most PD patients are sleepy because the alerting activity of the reticular formation is not happening. So they sit and sleep. No? So all these contribute to the associative functions of basal ganglia disorders. So this is the, no, don't know. Here I will tell that you remember, you need not remember the whole structure. Pallidothalamo-cortex, motor. So in between so many structures are coming that you need not remember. Every output in the 5 circuit is pallidothalamo-cortical. Pallidothalamo-cortical, that is the output, and starting area is different. It starts from the motor cortex, it is motor circuit. So motor cortex, lobus pallidus, thalamus, cortex. In between you have got the striatum, subthalamic nucleus, that and all. You can study when you do a selective circuit dysfunction in some disorders. Otherwise, just remember motor cortex. Through the pallidothalamo-cortex is motor circuit. Oculomotor is from the frontal eye field and also the parietal eye field. You have got a parietal eye field and a frontal eye field. From there, pallidothalamo-cortical. So starting area is the eye field, pallidothalamo-cortical is oculomotor. So supposing somebody is asking question, quickly can say the area where it starts and ends, start is different, end is the same. So starting is eye field, pallidothalamo-cortical, that is oculomotor circuit. Then you have got the dorsolateral prefrontal circuit, that is a dorsolateral frontal cortex, pallidothalamo-cortical. That is dorsolateral prefrontal or the associative circuit. Then you have got the medial orbitofrontal, that is the anterior cingulate region. That is the preservation of self and species related functions. So it goes to the ventral striatum, that's the olfactory tubercle nucleus accumbens, pallidothalamo-cortical. That is medial orbitofrontal circuit. And then you got the limbic circuit, starts from the limbic area, then go through the again pallidothalamo-cortical. So these are the 5 circuits. So what are these circuits doing? The dorsolateral prefrontal circuit, executive function, motor planning, organization, designing which stimuli to attend to, and shifting of sets. Supposing you are listening to a song, suddenly you understand that you have a session and you wish to attend. So you have to inhibit that one and come to, that is called set shifting. You are in a set, you are in a function. If you want to go away from this, you have to stop this and shift to another activity. That is called set shifting function. We always do that. You have got condition called palinopsia, the visual path is sometimes I would have mentioned. So you see an object and you recognize this is a pen, and the pen is removed and the book is showed. Then you have to erase the pen and then only register the book. That is called set shifting. There are situations where the previous image is not erased. So when the book is shown, also patient will tell pen. That is called palinopsia. So failure of response inhibition and set shifting. So it inhibits something and shift to the next mode so that you keep on functioning. So that is done by the dorsolateral prefrontal area. Anterior cingulate is motivational behavior, and impaired motivation with extreme degree will result in akinetic mutism. Completely motor and communicative, everything is locked down, and that is the end stage when you are akinetic and mute. That happens when the anterior cingulate circuit is affected. And medial orbitofrontal, emotional life, personality, response, judgment, arousal, motivation, affect, and emotional incontinence, so many things. And irritability, undue familiarity. So with the strangers, patients will go and talk to strangers and show familiarity. They do not know who is their own people. So those things all happen when the medial or FTD patients, they will go and engage with all those people on the road. Say, how are you? Did you take food? So that is all by the medial orbitofrontal circuit, because they fail to understand who is their own family members. So their social cognition limit fails. This happens in these overlap syndromes, FTD, PD syndromes, NPH, that kind of disorders. So what is this theory? It is showing so what happens? You can regain control at any time by clicking on your screen. Are you able to hear?
Yes, madam, we are able to hear, madam.
Okay. So something happens. So you can regain control. So what I should approve? One dialogue.
No need to do anything, madam.
Okay, but because it is sitting on my PPT. Okay,
it's going, yes.
I should approve or decline. What you should do?
What is it showing, madam?
It is showing tang, tom, to, dup, like that some language is there. And you can regain control at any time by clicking on your screen. So
No need to approve, madam. No need to approve that.
Okay. But it sits on my PPT, no?
We can close it or something, madam.
I'll decline.
Yes, ma'am, decline.
Okay, I decline.
Yes.
Then how does, we saw the various circuits, and these circuits are not anatomical pathways. They are functional pathways. You know that it is identified by using harsh radish peroxidase labeled viruses. So these viruses are labeled with the harsh radish peroxidase, and they are traced, and these circuits have been identified. So how do they control? They form the extensive thalamocortical network. We saw all the pallidothalamo-cortical, so many pallidothalamo-cortical, I told. So that forms an extensive thalamocortical network, and it forms a brainstem motor network. So from the brainstem to the spinal cord is the brainstem motor network. That is the final executive organ. And the cognition, planning, goal setting, inhibiting, facilitating is through the thalamocortical network. That's why I told all the 5 circuits pallidothalamo-cortical. So it's an extensive thalamocortical network for the cognitive association, and brainstem motor control for execution. So particular patterns of movement such as saccade, mastication, vocalization, making sound, swallowing, locomotion are generated by specific neural networks in the brainstem that I will not be going into. See, you have got that each one is a topic, swallowing and vocalization. They are all different topics by themselves. So we'll go through the aspects which we had planned today, that is the gross motor control. So they are also motor functions, but they have got different circuits. So what is this? 2 people entered the waiting room, it is showing. What is that? So it is not moving. What I should do? 2 people entered the waiting room. So the PPT is not moving. Some newcomers came, huh?
Ma'am, we'll take a note. You can continue. No problem.
Because the PPT is not moving. It is stuck there.
Can you try now, ma'am?
Bow by Gia, VG, bow, VG. What is it? Bow. It is stuck there. What is that? Some virus, huh? I don't know.
Can you try now, ma'am?
Now we can try, ma'am.
It is refusing to move.
But
now it is.
No, it's yes.
Okay. So we saw the thalamocortical networks and the brainstem spinal cord networks. So these are you saw the cortical area, subcortical gray matter, the link with the spinal cord, the various networks. Now we will see quickly the special motor activity. I am not going to elaborate. I have told that is vocalization, swallowing, and gastric motility disorders. They will not go into. So the important neurotransmitters, dopamine pathways from the substantia nigra to the striatum, that is caudate nucleus and putamen. So dopamine pathway, nigrostriatal, from the substantia nigra to the striatum. That is a dopamine pathway, nigrostriatal pathway, very important. Second is the GABA pathway, that is from the striatum to the substantia nigra. So dopamine from the substantia nigra to the striatum, and the reverse is GABA, and acetylcholine pathways from the cortex to the caudate nucleus and putamen. You know, acetylcholine is a memory molecule. So acetylcholine is for the cognitive understanding of what you are going to do. And multiple general pathways from the brainstem that secrete norepinephrine, serotonin, enkephalin, they are all synergistic neurotransmitters. So these are the main important neurotransmitters: dopamine, GABA, acetylcholine, and synergistic neurotransmitters like norepinephrine, serotonin, and enkephalin. So, we have grossly gone through the anatomy and pathology. What will happen if these circuits break down? If these circuits break down, you get an alteration in the tone. Because a particular tone is needed to carry out a movement, so it will not be happening, so it becomes altered. And alteration in the speed. The speed is not properly calculated. Alteration in the tone, rigidity. Alteration in the speed is slowness. Altered posture and movement, so you get imbalance. And praxis, motor control becomes effective in the non-paretic limb. So praxis become altered. And impaired voluntary control. Voluntarily, you cannot direct your body part to the right direction. And abnormal movement. So when these circuits break down, you get 6 important problems. One is alteration in the tone. Second is alteration in the speed, alteration in the posture and movement, alteration in the schema or the praxis, and impaired control of your own body part, impaired voluntary control, and you can get unwanted movements because the hyperdirect pathway corrects the unwanted movements. They get inside and produce abnormal movements. So what are these terms? So these things are happening. So what do we understand by these terms? So we get reduced speed. Tone, we have already had a separate session. Is the state of partial contraction always present in the normal muscle for maintenance of posture with minimal expenditure of energy? That I am not going into. And next is hypokinesia. Indicates decreased amplitude. So the peak of the movement. So hypokinesia is different from bradykinesia. Hypokinesia is decreased amplitude, whereas bradykinesia is decreased speed. So the amplitude through which you move your body, normally move like this means you move like this. So that is hypokinesia. You move slowly, that is bradykinesia. Akinesia is absence of movement. Bradyphrenia is mental slowing. We saw the cognitive circuit. So in basal ganglia disease, we say people are slow and right. Mental slowing is happening. So unlike an Alzheimer's or dementia patient, he will be quick and wrong. What did he have for breakfast? I took idli. He is least bothered. So it will be a wrong, quick answer. Whereas subcortical patients are slow and right. We call subcortical patients as slow and right because of the mental slowing. They take little more time, but they give the right answer. That is slow and right. All this happens in the absence of paralysis. If the amplitude is reduced and the limb is paralyzed, it is not hypokinesia. If the speed is reduced and the limb is paralyzed, it is not bradykinesia. So it is all these things happen in a non-paralyzed limb. The limb is not paralyzed. Then this hypokinesia, bradykinesia, akinesia, bradyphrenia applicable. So you have got increasing the speed and decreasing the speed. Both can happen. Hastening of the speed is called enhancement or festination. And reducing the speed, apart from the bradykinesia, rigidity and all those things, you have got freezing. So the major involuntary activities that happen due to excessive movement is festination, hastening, and inhibition or freezing. So tone, we know that it is a tension in the relaxed muscle. And what is rigidity? Rigidity is the plastic resistance to passive movement, which affects the agonist and the antagonist, and it is constant throughout the entire movement. So rigidity, unlike spasticity, is velocity dependent, and it increases when the speed is increased. Whereas rigidity is not velocity dependent, it is present throughout the movement, affects the agonist and the antagonist, and when it is having tremor, periodic modification of this rigidity by associated tremor is called cogwheel rigidity. If the rigidity is periodically altered by superimposed tremor, we call it as cogwheel rigidity. So now we know the movements can be hypokinetic movement, hyperkinetic movement, or a combination. So abnormal movements can be hypokinetic. Under that, bradykinesia, athetosis, and dystonia. These are abnormal movements which are slow, and abnormal movements which are fast may be tremor, tic, myoclonia, chorea, balismus, asterixis. These are all hyperkinetic movements, and you can have combination of hypokinetic and hyperkinetic. That's a mixture. So now we have seen what are all the things which happen: alteration in the tone, alteration in the speed, alteration in the posture, equilibrium, and abnormal movements happen. And these abnormal movements was the aim of this session, and that is slow movements or fast movement or mixed movement. Slow movement is bradykinesia, athetosis, and dystonia. Fast movement is tremor, tic, myoclonus, chorea, asterixis, and mixed. So now we have come to the involuntary movement. So patient has come with involuntary movement. We want to know whether it is slow or fast or mixed. So you have to describe the rate, if possible. Not always, sometimes. Most of the time it is possible. So what is the rate at which the movement is taking place? What is the range? Range means how many joints, whether it is involving only the fingers or it is focal, segmental, or generalized. That's the range. And rhythm. Rhythm means, do you have a predictable next movement? This movement went up, next movement will go down. That means rhythmic. This movement went up, next is also going up, means arrhythmic. So rhythm is the predictability of the involuntary movement. Direction. Is it above and down, up and down, horizontal, or multi-directional? Then what is the amplitude? We say hypokinesis amplitude. So whether the amplitude is decreased or increased. And what happens to these movements in sleep? And what happens to these movements when the patient is emotionally disturbed? And what is the effect of drugs on these movements? Can alcohol reduce or increase? And what is the phenomena called gesta antagonistica? That is sensory motor coordination. I'm sure you all know that the patients with oculomotor apraxia, they sometimes put their fingers on the inner canthus. Or people with jaw dystonia, they hold like this. So that is, what are you doing? You are touching the skin. You are sensing sensory stimuli, giving positive cortical tropism information properly by increasing the sensory input. So the movement gets corrected little more better. That is called gesta antagonistic. So is there any particular phenomena you can do that will help you to reduce the movement? So describe like this. And after you have described what your patient is having, you try to find out whether you can fit it into any of the structures that we went through. And after you have fitted, you know, certain group of disorders affect certain diseases affect certain types of pathways and their structures. So we try to understand the pathology from the anatomy. And after understanding the pathology, of course, you know the syndromic diagnosis and plan the treatment. So that is how you are going to approach. So we'll go one by one. This is a hyperkinetic movement. So what is a tremor? Involuntary and rhythmic oscillatory movement around a fixed point produced by alternating or irregularly synchronous contraction of reciprocally innervated muscles. So you have got an agonist, you have got an antagonist, you have got a fixator, you have got a synergist. So if the motor schema is correct, agonist will be activated, antagonist will be suppressed, synergist and fixator will help. If that is not happening for the desired period of time, after maintaining the posture for a lesser period than needed, the antagonistic will be facilitated. So it will pull down. Then immediately the agonistic will want to correct. So it will go up. So that is rhythmic repetitive oscillatory movement around a fixed point produced by alternating or irregularly synchronous contraction of reciprocally innervated. Reciprocally means one is agonist and is antagonist. So reciprocally innervated muscles are alternatingly contracting much before they are told to contract. So that is tremor. What are all the types of tremor? You have got a resting tremor. Resting posture has to be maintained properly. And if that is impaired, you get a resting tremor. So tremor in a body part that is completely supported and resting. That is called a resting tremor. You know the classical drum beating tremor, pill rolling tremor. They are all resting tremors. So tremor in a body part that is completely supported and resting. What is action tremor? Tremor occurring during voluntary actions. So tremor occurring during voluntary action is action tremor. What is postural tremor? When a body part is voluntarily maintained against gravity. So when a body part is voluntarily maintained against a gravity, and you get a postural tremor. So during the range of movement, you get a tremor. That's action tremor. You maintain a posture, you get the tremor. It's a postural tremor. And kinetic tremor during guided voluntary movement. So you are moving your finger towards the nose. So you get a movement. That is a kinetic tremor. And it can be simple kinetic tremor when you are moving without any fixed target, or an intention tremor where the kinetic tremor increases in amplitude during the pursuit of a target. So it can be simple kinetic tremor where the target is not fixed, or an intention tremor where the target is fixed. So you can have a resting tremor, you can have an action tremor, you can have a postural tremor, and you can get a kinetic tremor. So what is an action tremor? It could be, action tremor could be for the intention tremor, target, or isometric tremor, evoked by voluntary muscle contraction without movement. So you are running fast and then suddenly coming to a standstill, you know that your muscles will contract and your body will tremble. That is isometric. The action is not going on, the body is resting, but it is trembling. And task-specific tremors are during task. So you are doing writing and you get a tremor, it is primary writing tremor. So primary writing tremor is when you are having a particular task and the tremor is coming, that is pronation and supination tremor. Elicit, so you tell the patient to write, so you get a pronation, supination movement. That is a typical primary writing tremor. You can have dystonic posture, focal, segmental, generalized in addition to pronation, supination movement, and holding like that, holding like this. All these are involuntary movements which come during tremor. But the tremor itself, you can have a dystonia, you can have myoclonus, you can have a tremor. Tremor is generally pronation, supination movement. And you have got two types of writing tremors. One is type A and type B. Type A appears during the act of writing, and type B when the position for writing is adopted. So you just trying to hold the pen and hold, and the tremor comes, it is type B. And you started normally and you are continuing, then it is coming, it's type A. What is the importance? It is for rehabilitation purpose. The one which comes halfway into the writing is rehabilitated differently from the one which comes from the starting itself. And you have got the musician's tremor, voice tremor, which golfer's tremor, which happens during the action of singing and action of playing. They are all task-specific tremors. So writing tremor is a task-specific tremor. Musician's tremor, golfer's tremor, all these tremors are there. Then intention tremor occurs during the most demanding part of the active movement. The most demanding part of the active movement is reaching the target. So then only it is coming. That is called intention tremor. So it is a problem of exacting and precisely projecting. So when there is a problem in exacting the motor speed and precisely reaching the body part to the target, that phenomena gets impaired, then you get this movement. And it is a proximal movement. Intention tremor is not a distal tremor, it's the proximal. So the whole body goes like this. So it's an irregular, proximal, more or less rhythmic movement. So intention tremor, we should not call all the clumsiness the patient shows as intention tremor. It's a proximal tremor. So whole body moves to and fro. So it's a proximal tremor. So next is the orthostatic tremor. So what is orthostatic tremor? Mainly affects the legs and the trunk. So presence on standing. So when you are standing, it becomes manifest. And a patient may tell about leg cramps. Patient may say, I'm getting leg cramps. And they can have tetanic contraction of calf muscle. So when they start standing, you may think it is not organic if you do not know that. And if you can palpate the muscle and feel the tremor, and you can auscultate the muscle, you get a thumping sound. And electrophysiologically, it will show 14 to 16 hertz tremor. So that is primary orthostatic tremor in the leg. So tremor, we have finished grossly what we need. Commonest is resting tremor and intention tremor, and you have got the task-specific tremors. Then you have got the chorea. What is chorea? Chorea is a quasi-purposive. It's a semi-purposive movement. Apparently, initially, the children with chorea get beaten because they lift a cup and drop it. And they try to lift a comb and try to act as if they are combing their hair. When the involuntary movement comes, they merge it with the voluntary movement. So that is why it looks like a quasi-purposive or a semi-purposive movement. These children try to correct it by trying to link it to the voluntary act. So it is quasi-purposive. non-repetitive. Chorea is generally not repetitive. That way I can differentiate it from tics. So non-repetitive, jerky, distal movements. So quasi-purposive, non-repetitive, jerky, distal movements. And it can involve the limbs. It can involve the facial structures like grimacing. And it can produce peculiar respiratory sounds. And excessive, quick, poorly sustained voluntary movement. So voluntary movements are poorly sustained. There is hypotonia in the limb which is affected by chorea. You can get pendular knee jerk or a hung up reflex. Because of the hypotonia, you can get a pendular knee jerk. When a chorea gets incorporated into the jerking component, you get a hung up reflex. You get the milkmaid's grip. All of you are very familiar with this. And patient will not be able to sustain the tongue out. It is called lizard's tongue. Quick pronator sign. You have got a slow pronator sign. You tell the patient to stretch the hand out, slowly pronating. That is a subtle pyramidal deficit. Whereas chorea is you hold like this quick. When a chorea movement comes quickly. So it's a quick pronator sign. Slow pronator sign is a subtle pyramidal weakness. Whereas quick pronator sign is a chorea. If it is unilateral, you call it as hemichorea. And the pathology is in the caudate nucleus. And the balism, violent swinging movement, which is proximal. Chorea is distal, whereas balism is proximal more than distal and involves the distal part also. And it is one involuntary movement which persists in sleep, and the structure involved is subthalamic nucleus. Then you have got the myoclonus. Myoclonus is defined as a sudden shock-like contraction of a single muscle, a group of muscles, or the whole person. So it can be a focal jerk, it can be a segmental twitch, or it can throw the patient to the ground. When the whole person is involved, it will throw the patient to the ground. And it can be epileptic or non-epileptic myoclonus. Epileptic myoclonus, the term is used when the patient has associated loss of consciousness. If the consciousness is not lost, it is non-epileptic myoclonus. It can be cortical, subcortical, or spinal. Cortical myoclonus is the juvenile myoclonic epilepsy of Johns. You know, early morning they get myoclonic jerks, and over a period of time they start losing their consciousness. That is cortical. Subcortical classical example, all of you would have seen SSP, slow myoclonus. So subcortical myoclonus classical example is SSP, where the myoclonus is slow. And spinal, if you have a segment of viral ganglionitis, and the limb is paralyzed below, at that segment you can get a quick twitching of the muscle, that is spinal myoclonus. So cortical is epileptic, subcortical is SSP, spinal is spinal ganglionitis. Then you have got the tics, which are hyperkinetic movements. Again, tics. So what are tics? They are convulsive, they are repetitive, voluntary, controllable, but build up eventually and rebound. So voluntarily controllable. So supposing you are going for an interview, by voluntary, unlike chorea, which you cannot control, tics can be controlled. But once you come out of the interview, you rebound it. That is called bottling the tics and releasing. In a situation, because of your voluntary control, you can bottle it up, but once you come out, you release it. So they are sudden, abrupt, unpredictable, brief, and they are, unlike chorea, they are repetitive. Chorea is non-repetitive. Chorea cannot be voluntarily controlled. Tics are repetitive and can be controlled, and they can persist in sleep. So these are the hyperkinetic movements. Now we will come to the hypokinetic. Under that, you have got athetosis. That is inability to sustain the fingers, toes, or tongue in any part of the body in any one position. It's a slow, sinuous, purposeless rhythmic movement which flows from one joint to another. So it's a slow, so patient cannot maintain posture for some time because of the slow, sinuous, rhythmic, purposeless movement which flows from one joint to another, and the pathology is in the striatum. Then you have got the dystonia. Dystonia is a syndrome dominated by sustained muscle contraction, resulting in twisting and repetitive movement. And if the peak of the movement persists for more than 1 minute, we call it as a dystonic posture. You call it as a dystonic movement if the duration is 30 seconds to 1 minute. If it is more than 1 minute, we call it as a dystonic posture. And when the dystonic posture comes, patients go into contractures. So that is dystonic posture. If the peak of the movement lasts for 30 seconds to 1 minute, it is dystonic movement. It lasts for more than 1 minute, it is dystonic posture. Dystonic posture is likely to lead to degenerative changes and ankylosis of the joints across which the twisting is taking place. So how are you going to classify? They can be classified by cause. So it can be a idiopathic dystonia, which is sporadic, or it can be familial, or it can be symptomatic. It can be secondary to some infections, or it can be secondary to trauma. It can be secondary to metabolic disorders. So it can be by cause, it is classified as idiopathic or symptomatic. Idiopathic, when you do not know the cause, it is sporadic or familial, and symptomatic, secondary to metabolic insult, infection, trauma, like that. And by age of onset, it is classified into childhood onset, that is below 12 years, adolescent onset, that is below 20 years, and adult onset, it is more than 20 years. So it can be classified by cause as idiopathic or symptomatic. It can be classified by age of onset as childhood onset, adolescent onset, or adult onset, and by distribution, by focal, when only one joint is involved, segmental, when more than one joint is involved, multifocal, when non-contiguous multiple joints are involved, generalized, when the trunk is involved, and hemidystonia, when it is in a hemiplegic pattern. And by association, we call it as primary dystonia. So by the associated other neurological abnormalities present or not, like that, it is classified as primary dystonia, dystonia plus. Primary dystonia means only dystonia. Dystonia musculorum deformans, olden days it is typical, now it is all DOIT genes. So that is primary dystonia. Dystonia is the only abnormality, nothing else is there. Dystonia plus is dystonia plus Parkinsonism, or dystonia plus ataxia. So that is dystonia plus. And dystonia is part of a heredodegenerative disorder. So patient is having multiple involvement of the neuraxis, of which he is also having a foot dystonia. That is dystonia is part of a heredodegenerative disorder. And paroxysmal dystonia, the kinesiogenic, non-kinesiogenic dystonias, they are coming episodically and going. When you run fast, you get a paroxysmal kinesiogenic dystonia. When you walk, you get a paroxysmal exertional dystonia. When you sleep, you get a paroxysmal hypnogenic dystonia. And paroxysmal non-kinesiogenic, that is spontaneously it is fluctuating. And diurnally fluctuating dystonia, Sagawa syndrome. It is not, it is there in the morning, it's not there in the evening. So these are all paroxysmal dystonias. And drug-induced dystonias, antipsychotics, use of antipsychotics, you get tardive dystonias. So by association with other parts of the neuraxis or not, or association with drugs used, or by the phenomenology, you classify them as primary dystonia, dystonia plus, dystonia as part of a heredodegenerative disorder, paroxysmal dystonias, and drug-induced dystonias. So now these are the abnormal movements, right range, by that you have described and you categorized and you found what it is. And then basal ganglia disorders affect posture and equilibrium. What is posture? Is ability to maintain body parts in desired alignment, in balance with the gravitational pull. When the gravity is pulling also, we are well aligned, that is posture. Equilibrium is stable maintenance of posture during rest and activity. Posture is only during rest. Equilibrium is during rest and activity. Movement is the ability of the organism to displace from one place to another. So movement is you are displacing from one plane to another, that is movement. And it involves short phasic contractions mediated through several reflexes. So several reflexes are involved. They are all controlled by the basal ganglia. That is postural and writing reflex, anti-gravity stretch, stepping, equilibrium, and propulsion. This and all, some many classes, small fragments we have discussed. I will not elaborate this. And gait is a learned motor skill, which is the most automatic of all automatic reflexes, in which the erect moving body is first supported on one leg and then the other. So that is the definition of gait. It is happening just automatically. You don't even think. And one leg is extending, another one is flexing, then the other one is extending, this one is flexing, it's just happening. So that is gait. Praxis is ability to formulate skilled movement in a non-paretic limb. So praxis is ability to formulate skilled movements like piano playing or doing some dancing movement or typing movement in a non-paretic limb based on command on stored complex information and previously learned movement. You have learned it before and that information is stored and on command you execute it. That is praxis. What is writing reflexes? It's a coordinated synergies that help to bring the body into upright position when tilted. So writing reflexes, when you push someone, they don't go and fall because of the writing reflexes. This involves visual, vestibular, proprioceptive error signal. So when you are not in proper position, vision will say you are displaced. Vestibular system will say you are displaced. Proprioceptive afferent copy will say you are displaced. And these error signals are matched in the basal ganglia and the proper schema is formed. So now we will go to the Parkinsonism. So we described all the involuntary movement, the phenomenology of gait and balance. So gait and balance is mainly affected in the Parkinsonian disorders. And what is the ancient Indian knowledge on this disorder? We call it Charaka Samhidya, written in the 800 BC. It says that Kambavada. It is called Kambavada. And he classified it as Siro Kamba, when the head is having involuntary movement. Karo Kamba, classical, hand is having. Pada Kamba, lower body Parkinsonism. Sarvanga Kamba, PSP plus MSA, those conditions, that the whole body is involved. And treatment was Naikurna seeds. That is the source of L-DOPA, that is Mucuna pruriens. And if you have, I always tell that Loga Samasta Sigino Bhavantu, Annadana, Vidyadana, Silchadana. That was our ancient culture. It was practiced. So in an era when even a comma or killing a mosquito in the compound wall is documented and applied for and with you claim for assuming activities, these Naikurna seeds were freely handed over to the British invaders for doing research because they found that this is helping our patients. And they asked our ancient practitioners, they simply gave it. So one L-DOPA we would have purchased the world. So it went from India. So always feel proud to be Indian. If you are proud of your mother only, you will contribute to the beauty of her. It is our duty. I am very old. I come from a very small background and you are all very young, energetic children. You should be motivated not to go to America or UK or Arabia. Sir, mother, life is short. You don't wait for anything. Time and tide does not wait. Serve your mother country. Feel proud of her most wonderful culture. Loga Samasta Sigino Bhavantu. Simply give everything free. And they patent our own products to us. No? That is the tragedy. So very beautiful description by Charaga and the treatment itself from India. So Kambavada. So Parkinson's disease, what is the definition? So now we saw the excessive movements, we are finished. We are coming to the Parkinson. That's a bigger chapter, so I kept it as the last part. So Parkinson's disease is a slowly progressive neurodegenerative disorder. And in the early stage, the motor symptoms predominant. But as the disease progresses, the circuits break down. We saw the extensive cognitive links. So even in the idiopathic PD, dorsolateral prefrontal circuit will get affected over a period of time. So there, by time limit, we change the definition. So in the early stage, motor symptoms predominant, but over a period of time, other symptoms, cognitive functions, and motor fluctuations, and many non-motor symptoms, neuropsychiatric symptoms get added on. The definition by James Parkinson is involuntary tremulous motion with lessened muscular power. That is a tremor is involuntary tremulous motion. Lessened muscular, he mentioned bradykinesia, I think, in parts, not in action. So the parts which are not moving, they're very slow. They look like a statue, even when supported, with a propensity to bend and trunk forward. That is posture abnormality, chromatocomia, to pass from the walking to the running pace. That is pulsion, propulsion, and retropulsion, and the senses and the intellect remaining unaltered. That was the definition by James Parkinson. Very beautiful description of all the features. So clinical neurology, well observed, whole person studied properly, and a beautiful definition is coined. So that is Parkinsonism, and we say the one clue, that is trap, tremor, rigidity, akinesia, partial instability. So Parkinsonism is tremor, rigidity, akinesia, and postural instability, and it traps you. Your motor activity is trapped in the Parkinson's disease. It's a terrible disease. So tremor, rigidity, akinesia, and postural instability is trap. So how are you going to diagnose? You got the criteria, that is a unified Parkinson's disease diagnostic criteria, UPDR score. I'm sure you know all this, and you have a mandatory criteria, bradykinesia. It should be demonstrable. So you keep on doing this kind of movement, the amplitude comes down, or tap your foot, the amplitude comes down, move like this, or shoulder, axial, any body part you can tell the patient to move. Amplitude and the speed coming down is bradykinesia. So plus one of the following, tremor, rigidity, partial instability. It is all there available. You can see these criteria. You apply it for 2-3 patients, then you become familiar with that. So you got a primary criteria and you got a supportive criteria. Mandatory thing is slowness, which should be demonstrable, with so many other parameters which qualify for idiopathic PD or Parkinson plus syndromes. This is easily available. You can download. I'm not elaborating that. So it's just theory only. So if the person has got Parkinsonism with other neurological signs, then you call it as, so idiopathic Parkinsonism, what we discussed, what we analyze, only estabrondal and bradykinesia plus. So if there are other things, Parkinson plus, so that becomes the other neurological signs like eye movement. So PSP, corticobasal ganglia disease, CBGD. If you are autonomic, it is MSA. If you have apraxia, it is CBD. If you have cerebral loss, it is MSA, CJD. So Parkinson plus is Parkinsonism is there, plus other signs are also there. Under that, we have all these conditions, and with each one of them, you make a diagnosis, whether it is PSP or you look for autonomic functions, you look for praxis, you look for cerebellar signs, and dementia. So you have got a dementia with Parkinsonism, diffuse Lewy body disease, visual hallucinations, dementia and Parkinsonism, and PD plus AD overlap syndromes, CBJD, cortex also degenerates, so early dementia will come. Juvenile Huntington's disease, we call it as Westball variant. There the chorea will not be dominant. It will be Parkinsonian features. Juvenile Huntington's. Classical Huntington's comes usually in the 3rd or 4th decade. So juvenile Huntington's present with the young onset PD and with the dementia. Hallertau-Spatz disease or neurodegeneration with brain iron accumulation. Now this term Hallertau-Spatz is removed by the WHO. I'm sure you know that Hallertau-Spatz was a doctor of Hitler. He used live patients, he killed them, opened their brain, and he demonstrated these people have iron deposition in the basal ganglia by killing live people. So that term is now, Hallertau-Spatz term is removed, and it is called neurodegeneration with the brain iron accumulation or pantothenate kinase related disorders. So that is the term, NBIA or pantothenate kinase enzyme related disorders. So the Hallertau-Spatz term should not be used anymore because it is unethical practices. So that is one. That is the primary Parkinsonism. Second is the Parkinson plus syndrome. Then third group is the Parkinsonism secondary to non-etiological agents. That is use of neuroleptics or toxins like manganese, pesticides, MPTP that is present in ganja. Methyl terate tetrahydropyridine. So people who smoke ganja, they get Parkinson, Wilson's disease, then copper, calcium dysregulation, then tumors of the basal ganglia, NPH, head injury. That one Muhammad Ali person developed Parkinsonism, punch drunk syndrome or dementia pugilistica, then multi-infarct Parkinsonism, which is lower body PD, and you can have all these excess or slow movement, psychogenic, if the person has seen some patients that can imitate. So you should not forget psychogenic movement disorders. All kinds of bizarre movements can be organic. So many psychiatric patients get labeled as organic, and organic patients get labeled as psychiatric. All this happens. So psychogenic is very common in movement disorder. Then we have got the akinetorigid without a tremor. No? So akinetorigid symptoms imply slowness of initiation and carrying out the activity involving upper body more than the lower body. So akinetorigid syndromes are not lower body. Vascular PDs are lower body. The akinetorigid degenerations are involving the upper body more than the lower body with abnormal stiffness due to increase in the tone of the agonist and antagonist with or without cogwheel. Cogwheel is generally not there in the classical akinetorigid syndromes. That's a group by itself. So primary Parkinsonism, Parkinson plus syndrome, Parkinsonism secondary to known causes, and you have got the akinetorigid variety of PDs, and diagnosis is clinical. They have bradykinesia, bradyphrenia, hypokinesia, postural instability, tremor can accompany, but it will be the last and the simplest. So akinetorigid is having mainly the hypokinesia related syndromes. They form a group by themselves because they are difficult to treat and prognosis not good. So that is the akinetorigid varieties. This is a patient, you can see the upper body. He is having no stooped posture. He has no expression and his limbs are not fluid. The video, I think it's not there. You think it's not there. So that is a akinetorigid syndrome. And classification of akinetorigid syndrome: asymmetrical, symmetrical, and miscellaneous. So akinetorigid syndrome can be asymmetrical when it can be sometimes the idiopathic PD itself akinetorigid dominant, or corticobasal syndrome CBDs, or you can have symmetrical akinetorigid, that is PSP and MSA, and miscellaneous akinetorigid syndromes, vascular, metabolic, traumatic, toxic, DLBD, and other conditions. Then you have got multi-system diseases with under multi-system involvement. You have got late onset Parkinsonism with multi-system involvement is PSP, CBD, MSA, DLBD, Parkinsonism, dementia with ALS. So that is multiple part of the neuroaxis, but the common thing is Parkinsonism. But Parkinsonism part may be mildly expressed, but there is other diseases are dominant. That is the heredodegenerative disorders, where the Parkinsonism is not the primary feature. Many other features are there. Parkinson symptoms are coming. That is Huntington's disease, chorea with PD, ataxia with PD, Wilson's multiaxial, then hereditary aceruloplasminemia, hypoceruloplasminemia, NBIA disorders, X-linked dystonia, Parkinsonism, Jesman's Troxus, that is prion disease, where ataxia myoclonus dominate, neuronal ceroid lipofuscinosis, and mitochondrial cytopathies. These are other conditions where you get Parkinsonism in association dominated by other features. Here Parkinsonism dominates and others accompany. That is the multisystem PD variant, whereas heredodegenerative, those things dominate and Parkinsonism is there. So common thing under all this, you remember the hypokinetic, under that bradykinesia, that is Parkinsonism, Parkinsonism plus syndrome, secondary Parkinsonism, Parkinsonism with multisystem involvement, and heredodegenerative Parkinsonism, akinetorigid syndromes. These are the various categorization, common thing being Parkinson's disease. Components are bradykinesia, rigidity, eye signs and speech, autonomic features, praxis, gait and postural abnormality, and cognition, dystonia, tremor. So when they come with the Parkinsonian features, you look for bradykinesia, rigidity, eye signs, speech involvement, autonomic features, praxis, gait and posture abnormality, cognition, dystonia, and tremor related features. So this is a patient who has a alien hand. So when he is told to adopt postures,
few days.
So patient says that his hand will not cooperate. When he is trying to adopt the posture of keeping both hands across the trunk, He has to chase and capture the hand. That's a praxis disorder. So it's not a paralyzed limb. So what he says, he will not obey me. It's an alien hand. Seen in CBDs. Cortical basal ganglia degeneration, apraxia. So he has to do several kinds of vague movements. Finally, he will catch hold of his hand. So what he is saying, I have to go through a circuitous route and finally catch hold of the hand. And then when he catches, he reaches the posture. What he says, this fellow will not obey me. That is what he says. So that is alien hand. So this is a shuffling, festination, fast. Let me see the videos. I think the video is not playing. Huh? Why it is not playing? I don't know. We saw it, no?
We can hear the audio, ma'am, but we can't see the video.
I don't know what. If my son is there, he would have helped. I don't know what to do. No, what is happening? We'll go to the next one. So, you got posture, as I told initially, gait involves right. Postural writing reflex, integration and initiation is corticospinal tract. Automatic movements is by the extrapyramidal, that's the rate, range, rhythm, direction, amplitude. Coordination is by cerebellum. Subjective awareness is proprioception. That is the alien hand. If the awareness, positive cortical tropism is not there, the hand behaves as if it is another individual. That's the video which you saw first. And during skilled movements, skilled purposeful movement means what happens in those things, that is typing movement, music, no? So during skilled movements, posture control integrates different systems, including cognition. So if you have to type, you have to think of what you're going to type. You have to put your correct fingers in the proper position, put full stop, comma, space. So it puts multiple factors, including cognition, and carries out that movement. And they can be egocentric movement or body-centered, exocentric or environment-centered, or geocentric or gravity-centered. So all these get affected. Body-centered movements can be affected. Environmental-centered movements can be affected. Gravity-assisted movements can be affected. And for this, you have got alignment of body parts for erect posture, remodeling for voluntary movement. So when you want to do a voluntary movement, the posture has to be remodeled. And steady dynamics. If you are dancing continuously, you are remodeling. So steady dynamics happens during dancing. And this all should happen with minimum energy. You should not become exhausted during your routine walking. So the purpose is align body parts for erect posture, remodel for voluntary movement, use steady dynamics during dancing movements like fast movement, and do all this at minimal expenditure of energy. And so we have got this pathophysiological staging. That is why nowadays we say that smell, the earliest sign the patient sensitive for smell becomes impaired. He may show complaints like constipation, which can be ignored, which may be ignored. So earliest change in thing is taking place in the dorsal motor nucleus of the vagus and the olfactory tract. So that results in constipation and reduced smell. And next is in the locus coeruleus and subcoeruleus complex. So sleep and mood becomes altered. Third is the substantia nigra when you diagnose your case. And last is the cognitive, then psychosis, and the cognitive functions become affected. So earliest thing is in the olfactory tract and the vagus, pathology. That is a pathology, postmortem pathologic changes. So these things will be ignored. We will not give importance. And then when they come with the motor symptoms only, we diagnose. That's the third phase. So by the time patient comes to with the early motor symptoms itself, the degeneration has progressed a lot and is already reached the third phase. So gait disorders, you know, lower level, middle level, higher level, NUT classification. And lower level is muscles, tendons, joints, and nerves, roots. Middle level is spinal cord, basal ganglia, cerebellum. Higher level is cortex and cognition. And for maintaining balance, you have got writing reflex, support reaction, anticipatory reaction, reactive postural response. When you suddenly see a vehicle, you have to react to the unexpected thing and produce a motor response. Rescue, once you have fallen, you have to rescue and prevent yourself from injury. And protective reaction. So many reactions are involved in balance. What are involved in gait, we just now saw. What is involved in maintaining? Posture is writing reflex, supporting reaction, anticipatory reaction. You expect there's a turning scooter might come. And you have not anticipated something has come and you react to what you saw. And you have not even reacted, you have fallen, so rescue from injury. And protective reactions. These are the things which act during equilibrium. And the highest level is the apraxia, which is of praxis, freezing, shuffling. All these movements come under the highest level gait disorder. So patient may become stuck, cannot move at all. He may feel glued to the floor, that is gait apraxia. He may festinate and shuffle. That was that video which did not play. That's the fast movement which happens in basal ganglia disease. And what is freezing? Brief episodes of inability to initiate or continue locomotion. Suddenly you become frozen for brief period. You cannot initiate or continue movement, and it happens during change of movement from one to another or during stress. It can be at the beginning, it can be during walking, or it can be during test situation, or it can be at the end. And it can show response to motor or behavioral tricks. That is why we say you play music, the freezing will improve. You draw lines in the floor, the freezing will improve. So these are all early rehabilitation. You tell the patient to walk with the music in his ear, or tell the patient to walk in his house with the red lines or stripes drawn in the floor. So those things improve the freezing. So fall is very important for you. So people fall and it is very serious matter. So I thought I will cover that. As you know, I have just given you a broad outline only. And when we take cases, we keep on discussing this in bits and pieces. A fall is defined as an unexpected event in which the person comes to rest on the ground, floor, or a lower level, which is not due to a stroke or a seizure. So fall is a situation where the person suddenly comes to the ground, which is not due to a stroke or a seizure. That's the definition of fall. And you have to keep a fall calendar. Old people fall and fracture their limbs, and that's the end. So fall calendar is documentation of the event, the circumstance. Did you trip and fall? Was there a slippery floor? Somebody pushed you? Then it is not disease. So you document the event, circumstance, and the nature of the fall. That is called fall calendar. Any fall patient, you have to keep a fall calendar describing the event, circumstance, and characteristics of the fall. And multiple fall is having at least 2 falls per month is called multiple falls. It has to be seriously investigated. As I have told in some class, people with the PSP syndromes, they fall early when the other signs are not much. And many of these people are diagnosed as osteoarthritis. They get their knee joints replaced. Still they continue to fall. Then over a period of time, you know, it is PSP. So injurious falls are defined as falls that provoked visible injury. So they are more grave. So you have to take much more precautions. So you make a fall calendar, define whether it is multiple, and then are they injurious or not injurious, to define the gravity. And so a person who falls can be due to gait disorder. It can be due to postural instability. It can result in fractures, injuries, and fear of falling. You have fallen once and you refuse to walk. That is more dangerous. So that is fear of falling. These are the consequences. That results in immobilization. Immobilization leads to osteoporosis, social isolation, depression, secondary muscle wasting, and that becomes the doom for the person. The falls may be collapsing falls. So he said you should characterize the fall. Collapsing fall, it may be a seizure. It can be a syncope, or it can be orthostatic hypotension, suddenly collapse and fall. Or it can be a toppling fall while standing. It can be cataplexy attacks, drop attacks. No? They are toppling falls. So toppling falls due to postural imbalance can happen during changing position or posture. You may trip and fall, pyramidal disease, dystonia. You may freeze and you may fall due to freezing. And you can have unpatterned falls. That may be psychogenic, or sometimes even the PSP falls are unpatterned. And the falls in our situation, idiopathic PD, patients fall during turning, N-block turning, and they fall. Here the pathology is in the weak writing reflexes. CBD falls, they are postural falls. When they stand, they falls. They also have myoclonus, so postural falls. Whereas idiopathic PD, turning, during turning. Pivotal falls, you fall just like a log of wood or a tree which has been cut. That is pivotal falls. That is due to pedunculopontine oscillator complex abnormality. MSA fall is autonomic. So you get an orthostatic dizziness, giddiness, palpitation, and then you fall. DLBD, you get fall due to carotid sinus sensitivity. So it's a syncope. And you can have fall and freezing and REM sleep behavioral disorders which are linked to the mesencephalic reticular formation. That is why when you treat Parkinsonism features with dopamine, these patients do not respond because it is not due to dopamine. We saw the neurotransmitter in the mesencephalic reticular formation is acetylcholine. And the structures involve locus coeruleus is noradrenaline. So these are the neurotransmitters and these are the structures. That is why falls are resistant. So patients will be concerned. So unfortunately, the drugs are not helping. You have to use other protective effects against falls. And dopamine improves the step length, speed, but vertical braking ability to improve falls does not happen. As falls are not due to basal ganglia or dopamine. It is due to cortex or PPN cholinergic denervation, reticular formation. So because of all those things, falls do not improve when we treat patients with dopa. Then you have got eye movements, you have got the frontal eye field, you have got the parietal eye field and superior colliculus. They are extensively linked through the basal ganglia. So eye movement abnormality can happen even in idiopathic Parkinsonism when it is slowing of horizontal eye movement or cogwheel pursuit. You get upgaze involvement in your hydrocephalus, and you get upgaze involvement in PSP, but typical PSP is down gaze. And so we tell that horizontal gaze in idiopathic PD, down gaze is in PSP, upgaze in tactile pathology, NPH hydrocephalus, even though upgaze does happen in PSP, and MSA is more of upgaze. And eye movements can be normal in MSA. Then depression and apathy because of the executive circuit, dorsolateral prefrontal pathway, when it is impaired, you get poor executive function. Then inhibition of thalamocortical neurons. So you do lack your motivation. So you become apathetic because of this circuit degeneration. In addition to the Parkinsonian features, patient become apathetic, depressed, mainly due to thalamocortical projections impairment and dorsolateral prefrontal circuit impairment. Autonomic dysfunction, as you know, you get it in MSAs because Lewy body is the pathology in PD, CBD, and MSA. So if the Lewy body is located in the substantia nigra, you get the idiopathic PD. If the Lewy body is degenerating from the autonomic ganglia, you get the MSAs. So Lewy body is there everywhere, depending on where it degenerates. If it starts degenerating the occipital lobe, you get DLBD. The substantia nigra, you get idiopathic PD. In the autonomic ganglia, you get the MSAs and MSA-CP. So it's primarily a Lewy body disease. In which location the Lewy body degenerates determines the type of phenotype. Sleep disturbances are very common because all kinds of sleep disturbances occur due to abnormality in the serotonin mechanisms. That also I will not go into elaborate. Sleep is a topic by itself. I think by now you will be all feeling tired. And GAT disturbances due to autonomic involvement. I said the earliest thing is vagal denervation. That process produces a lot of GAT symptoms in these patients, which are very difficult and disabling to patient. Then you get freezing and falls. They are gait. So eye signs we saw, cognitive features we saw, falls we saw, gait. These are all problems of Parkinsonian patients. And they are freezing and falls are difficult to handle. In advanced PD, we use non-pharmacological methods like music or producing secondary sensory stimuli And you have to change the environment, make the environment safe, and you have to use assisted movement so that falls are reduced. So PSP, you know, it's a most common. Should I continue? Are you all tired or what? No?
Can continue.
Continue. So I
Yes,
will
ma'am.
quickly go through this. This is a common, all of you would have seen. It's a most common atypical PD. Usually happens in the late 6th decade with a relatively reduced survival. They have got axial rigidity. They have poor postural writing reflexes. They have severe faults. They have pseudo-bulbar features, and they have frontal lobe signs, and it is unresponsive to treatment. You should never try dopa agonist in this condition. Some of them may respond to dopa for some time, but not the classical way of dopa responsiveness you see in idiopathic PD. Blink rate becomes reduced, eye signs are abnormal. The doll's eye is initially okay, later it deteriorates, and they can have a subcortical type of dementia, surprise lid retraction, which is called Collier sign, and you get pathology is a tauopathy, and it is mostly sporadic, and the abnormalities, the microtubule associated protein, there is mitochondrial dysfunction and oxidative stress. And you've got so many variants with the apraxia, with the Parkinsonism, with the cortical features and behavioral features. So based on that, so many variants are there. What is the primary feature? You put it as the primary diagnosis, and with the whatever additional symptoms are coming, we add so many parameters to that. And you have the Mickey Mouse sign, and you have got the hummingbird sign in the midbrain due to degeneration of the dorsal midbrain. And that you can see that hummingbird, the beak of the bird, the head and the belly is also called pregnant pond sign or humming. This is the morning glory sign, where the dorsal part is degenerated, ventral part is like the flower. MSA is autonomic, so it can be MSA C. So it is a synucleinopathy, a variable combination of Parkinsonism, autonomic dysfunction, cerebellar dysfunction, with or without pyramidal, and they are in general only the P type might respond to Syndapa for some time. Autonomic functions has to be managed by various symptom modifying medications. So there is a synucleinopathy, as I said, and you have got cerebellar involvements, you have got striatal involvement, you have got autonomic involvement. And MSAP is if it is dominated by Parkinsonian features, and you call it as MSAC if it is cerebellar features. Cerebellar features, you find the hot cross bund sign. MSAP, you find the striatal signal change in the radiology, and you get urinary bladder bowel symptoms dominating. This is the hot cross bund sign you find in MSAP, hot cross bun appearance in the ponds in MSAC, and MSAP is the striatal sign. You see the putamen hyperintensity, that is MSAP. And you got so many points in favor of MSAP. This also you will get it like the UPDR scores. This is all from the textbook, so I am not elaborating. You can just read. After you have finished the basic understanding, you can go through this. And I'm not imaging, mainly remember hot cross bund sign and the striatal sign. Corticobasal ganglia degeneration, that's cortical signs will be there. So they'll have cortical sensory loss, they'll have myoclonus, they have dystonia. In addition, they are having Parkinsonism, and the asymmetrical ventricular dilatation is what you see in these patients. So it's because of the asymmetrical frontoparietal atrophy, and because of the apraxia, they have got the apraxic link. That patient at CBD in the early phase. So cortical signs are dominating. And this also you can take it from the continuum. There is a continuum series where how to differentiate various atypical Parkinsonism. The points I told only, depending on whichever site is overadded, you categorize them into that category. It is of prognostic relevant, predicting life expectancy, what all complications they are going to have. So treatment options are very, very poor. There are only rehabilitatory tools. So that all you can talk to the patient after categorizing them, and what are all the genes that are linked and what are the combination. This also get in the continuum. And by protein that is abnormal, they are classified as amyloid protein, Alzheimer's disease, ubiquitin proteasome, Parkinson's disease and their mutations, synucleinopathy, MSA, DLBD, tauopathy, PSP, AD, FTD, and polyglutamine Huntington's spinocerebellar ataxia, prion disease, CJD. So that is based on the proteins, they are categorized like that. And NPH, apraxia, dementia, incontinence, and I'm not going to elaborate. You can see the dilated ventricles with relatively preserved cortex. What you have to remember is this is a treatable dementia. Patient will have a triad of incontinence, gait apraxia, and lower body PD. When the patient is operated before cognition and bladder becomes impaired, the prognosis is very good. Shunting only, simple procedure. You see the dilated ventricle with relatively preserved cortex. Dilated ventricle with atrophic cortex is ex vacuo dilatation. Here it is a relatively preserved cortex, that is NPH. Then reward system, as I told, the reward circuits cause the feeling when turned. So you have to improve the reward system by encouraging the patients to move about and appreciate and motivate. So that is one rehabilitative tool that you have to use. And positive control tropism, I told that positive cortical tropism is important in movement by sensory system giving information. So when that becomes affected, you get these kind of movements. That's the frontal alien hand, classical alien hand, intermanual conflict, apraxias. All these are abnormal movements which are due to affection of the sensory pathways which are coordinating the motor pathways. So when the sensory compound we studied in the anatomy, when they become affected, you get all these kind of strange phenomena. This is the praxis circuit. You give the command goes to the supplementary motor area, schema is formed, then it goes to the motor area for the dominant side, for the non-dominant side through the anterior corpus callosum to the opposite supplementary motor area. This is a praxis circuit. Slowness due to nigrostriatal dopamine loss, and dopamine is very useful in the treatment of slowness. So freezing, festination, and periodic blinking, or these are various terms. Freezing, we have gone through. Unintentional increase in the speed is festination. Periodic blinking, that can also happen in patients with the basal ganglia. And you have got the centrally originating extrapyramidal system involvement, which gives rise to the decreased facial emotions. Centrally arising extrapyramidal system, which contributes to the facial motor nucleus, that results in emotional paralysis. Here you can see a patient who has retained emotion and motor paralysis, both can happen. And swallowing, bladder, constipation control, I will not go into here. I am sure you are all tired now. So that is the mini motor system or the intestinal motor system, and bladder control becomes abnormal due to Pontine maturation syndrome and the Lewy body degeneration, the autonomic ganglia. And this is the, you have got the sleep. This is a sleep circuit where the neurotransmitters that are involved in sleep, which travel through the thalamus and go to the cortex. So because of alteration in all these raphe-nucleus, locus coeruleus, and thalamus, and acetylcholine changes, sleep becomes altered. You can read all these things. These are easily available only. And RBD happens both in synucleinopathy and non-synucleinopathy because of the loss of sleep, atonia, and you have got a REM sleep. In the REM sleep, you have got a atonia. Because the atonia is lost due to altered sleep architecture in these conditions, there is no atonia. So they show a lot of motor movement. So that is RBD. And you have got behavioral disorders, that is due to reduced striatal dopamine transporters. So that results in abnormal behaviors in sleep. Yeah, due to loss of atonia, you get motor activity. So how are you going to treat them? You have to individualize the treatment. You ask the patient what is the most bothering thing. So how you can help this, you have to plan. Avoid treating non-bothersome symptoms. When the patient's a mild tremor is there, but it's not affecting, don't start to over-treating. And help by adding or subtracting medicines. Many people with minor psychotic symptoms, they'll be on antipsychotic, sometimes by reducing them, the Parkinsonism will go away. You can use extrapyramidal friendly antipsychotics like clozapine. Then you have to, whether to start early dopamine or not better, even though it is suggested that you can start and it doesn't really affect, but better to data tops. It's better to start dopamine agonist first and levodopa, better to preserve for the late phases, because the most effective, it can be used as a test to know whether it's idiopathic Parkinsonism, but better it can be. But nowadays people say that you give the benefit of dopa to every patient, but it is better to reserve it till late so that you have got some treatment options till late. So thank you. I speeded up in the fast because I thought you will all be getting tired. It's an elaborate topic. I have given the skeleton part of it. So let us hold on to the gods so that none of us get Parkinsonism and these kind of diseases become eradicated. We live useful life like Swami Vivekananda and such people. And when our Janma Uttesam is over, just leave Anayasena Maranam. So by holding on to God.